There are two staging systems that are used. One is the Rye staging system, the other is the Binet staging system. In the US, the standard staging system is the Rye staging system. The Europeans use the Binet. They're very similar and they are based on the same features. The Rye staging system has been simplified into 3 risk categories: low risk, intermediate risk, and high risk. Patients who have low risk disease have only a lymphocytosis, so only an elevated absolute lymphocyte count. The intermediate risk patients are those patients who have enlarged lymph nodes and or enlarged liver or spleen. And then the high risk patients are patients who have cytopenias by virtue of having the disease. And the cutoffs that we use are a hemoglobin of less than 11 or a platelet count of less than 100,000. And either of those two features would put patients into a high risk category or stage 3 or 4 disease by the Rye staging system. When patients need treatment and you're assessing them and trying to determine which treatment is the most appropriate treatment for a particular patient, the features that we think about are age. So does a patient belong into the older age category, or are they younger, more fit, and able to tolerate the more intensive treatments? Patients who are older don't tolerate the chemoimmunotherapies that we've been using for several years. Those are reserved for the younger patients who can tolerate the chemotherapy. We spoke about 17p deletion. That's clearly an important feature to assess before you choose treatment for a particular patient. And as I mentioned, also TP53 mutation status is an important feature to know, and they sort of go hand in hand. So we need to know the TP53 mutation status and the 17p deletion status. And then the other feature that we use is the immunoglobulin heavy chain variable gene sequence analysis. So for older patients, it's not as useful as for younger patients these days. So for younger patients who can tolerate chemoimmunotherapy, the best treatment for them is based on their IGVH mutation status. Patients who have an unmutated V gene, we know we can get them in remission with chemotherapy, but virtually all of them will relapse, and their remission duration is relatively short. So those are the patients that we prefer to manage with a small molecule inhibitor like ibrutinib, because treatments are changing so quickly that we feel like there will be something better coming along for those patients, and that we would like to spare them exposure to chemotherapy and the risks that come with chemotherapy like MDS and AML, in preference to a small molecule inhibitor where we will have an option to manage them probably more effectively at a later date. For the patients who are younger who have a mutated V gene, those are the patients who do exceptionally well with chemotherapy, chemoimmunotherapy, particularly FCR. So for a patient who doesn't have a 17p deletion and who has a mutated V gene, the standard treatment and recommendation would be for an FCR-based treatment, fludarabine, cyclophosphamide, and rituximab. And treatment with FCR for that patient population achieves complete remission in most of those patients, over 70% of them. And there is a large proportion of them, 55% or so, who will be progression-free for longer than 10 years. And there's discussion about perhaps some of those patients are cured, or many of those patients are cured. So the features that are important for the younger patients, again, are 17p, of course, and then mutation status, and FCR is the choice for patients who have a mutated V gene. And for patients with an unmutated V gene, the preference is for a small molecule inhibitor because it leaves other options open later and doesn't expose patients to the higher risk of getting myelodysplastic syndrome or AML.